Welcome to Talk Dizzy to Me, the show that brings you a comprehensive look into the complex field of dizziness. Now here are your hosts, vestibular physical therapist Dr. Abby Ross and Dr. Danielle Tolman.
Hi everyone, welcome back to Talk Dizzy to Me. I'm Dr. Abby Ross. I'm a vestibular physical therapist and neuroclinical specialist, joined by Dr. Danielle Tolman, also a vestibular physical therapist. And today we have a repeat offender. It's Dr. Shinbei, one of our favorite vestibular experts in our field. And actually, recently, I was posting about vestibular migraine in particular on our social media platforms, and I was sending people our episode when you were on 3 years ago now, 3 years ago, I can't believe it, where we discussed, I know, time flies. We discussed all things vestibular migraine then, so we wanted to do an update and maybe hit some questions that we didn't hit in our original episode, as well as talk about some new developments and evolution and care for vestibular migraine. So Dr. Bay, thank you for joining us.
Pleasure. Anytime.
Can you tell our audience a little bit about your background, how you got into the field, what you're doing now with your clinic?
Sure. So I'm a neurologist, with an interest in vestibular disorders. So mainly dealing with, vestibular disorders from the central side of things rather than the peripheral side. Long story, not very long story actually, come to think of it. When I was a resident, I got interested in, people who had vertigo, eye movement disorders, nystagmus, because it sounds like most of the other doctors were afraid of that and didn't want to deal with that. So for some reason, I got attracted to the field. Looked into it more, did my training in it, and well, here I am. Clinic-wise, we just moved, so we were in Frisco before, pretty far from Dallas. Now we are a bit closer to Dallas in Irving, but that's pretty much it. Location-wise, we've changed. We're still, seeing patients, from different states, within Texas as well, from other states. A little bit of change in the telemedicine rules, so licensing wise, I'm seeing patients in states that I'm licensed in, and unfortunately, the states where I can't get licensed in, because the process is different from state to state, then unfortunately I can't see patients from those states.
But still extremely helpful for everybody that, everyone that we've sent your way that has worked with you has only amazing things to say. So we're very excited to have you and your expertise today.
Thank you.
Why don't we kick things off with talking about some of the atypical symptoms of migraine? A lot of people still think that migraine comes with head pain, but that's not necessarily the case. So could you talk about that a little bit?
Oh, absolutely. So, we always think about migraine as headache, right? And then after the headache, we think about, the light sensitivity, noise sensitivity, nausea, and the visual aura, of course. But migraine, like you said, there are many different symptoms that can come with migraine. Of course, vertigo, dizziness, and vestibular migraine, unsteadiness, and of course, under the umbrella of vertigo, you have so many different sensations. You can have people who experience spinning, rocking, swaying, tumbling, floating sensations. You can have, spontaneous symptoms, meaning they just happen, and some that are triggered by head movement, positional changes. You can have symptoms that are provoked by visual types of stimuli. Of course, then you have the more unusual type of symptoms. Now I think we are beginning to recognize some ear symptoms as well. So tinnitus is one, ear pressure, ear pain. You have some unusual symptoms too, like little weird little bubbling sensations in the ear. Some people feel as if there's a little swelling in the ear. I've heard some people even say that there's like fluid coming out of the ear during migraine attacks, which we don't know what it is, but I'm hearing it in some of my patients. We're seeing, autonomic type of symptoms too. So some people get more teary-eyed. Some even get ptosis, where the eyelid starts to droop. Runny nose can happen. Dry mouth can happen. I have migraine myself. So, when I have my migraine, I yawn a lot when I get dry mouth. And that, to me, shows that the migraine is starting versus, say, a tension headache. You have other types of visual changes too. So, blurry vision, very common in migraine attack, and visual snow, where you see little pixels in your vision. Some people get rather unusual visual type of symptoms like palinopsia, where you see multiple images, or trailing. After you look at something, you look away, you see a trail of it behind it. Some people may even have, Alice in Wonderland type of symptoms visually, where things appear larger, smaller, closer, further away. Things can appear split in half. Things can change color. So tons of different symptoms can occur in migraine. The key is always trying to, recognize patterns. These are all, the migraine is a clinical diagnosis. So the key to making the diagnosis is to look at the association of the symptoms, how long they last, what brings them on, and that can give us clues as to, whether this is migraine or not.
So my next question was originally going to be adding in symptoms that you missed, but oh my gosh, that list was extensive. And so
I'm sure I missed a few things there.
I can't think of any. That was such a good list. I do want to ask though, given all these unusual quote unquote symptoms that can present in the same person, would we expect them to experience their same set of symptoms each episode, or could it change?
Correct. So that's a really good question. So we want to see the recurrence of symptoms, right? Of course, if you experience something unusual for the first time, don't blame it on migraine for sure. If you like some unusual neurological symptoms, definitely, go seek help, go to the ER, go to urgent care, call your PCP. If you have a neurologist, call your neurologist. Don't automatically blame migraine. Now, if we see that there is a consistent pattern, right, over time, that these symptoms tend to occur when you're experiencing your migraine attacks, then yes, we can attribute them to migraine. We need a few episodes at least before we can, draw that relationship and, blame it on migraine.
That's where tracking symptoms or being aware of what's going on and when they happen can be really helpful for patients when they go into their doctor to have a timeline set up for them. But what about broader, longer, bigger picture? Somebody who might have been experiencing migraine symptoms their entire life, what does an evolution of a migraine disorder look like over a lifespan? Will it remain the same? Does it change? What does that look like?
So it changes, definitely changes. It's partly a genetic condition, right? So you have to carry the genes for migraine, and which genes there are, it's different from each person. There are multiple genes that can be involved in it. The manifestations across your life will depend on, which genes are being active, what goes on in your body's internal environment, what is going on in the external environment. So, if you take like a just typical, simple example, right? Colic, for example, is recognized as maybe an early form of migraine, and that of course occurs in babies, right? In the pediatric group before puberty, you have several different types of migraine. You have, vertigo as a form of migraine. We can have abdominal migraine, so where children experience abdominal pain. You can have also cyclic vomiting, where you have the episodes of where they start throwing up and vomit, and all of these, most of the time, no headache in the pediatric population. A lot of children also experience Alice in Wonderland syndrome. So, I had that when I was a kid. I never knew what it was. It was a little bit trippy. I was lying in bed, and everything suddenly looked really far, small, look as if everything is in slow motion. I was like, ooh, trippy, interesting. And I go to bed, right? But, some things like that can happen in children, or they experience like with body sensations where they feel they become very big, very small, body parts suddenly, go missing, or, change in size, right? And then as puberty hits, there's of course the evolution to the more typical form of migraines that we are familiar with, where the headaches start to come in, and of course, in girls it tends to become more frequent, and then there's a drop off in boys, right? And then in women, you see that this change occurs, when you're having your period, when you're ovulating, a lot of women experience an increase in migraine attacks, and then when you're pregnant, they tend to go down. Once you deliver, migraine frequency goes up. And then as you start to approach menopause, there is, a decrease in the headache type of symptoms in the vast majority of patients. In some, of course, there is an increase in the headaches, but most people, there's a decrease. And that's when usually, right, you have the vestibular symptoms start to show up, the ones that we're familiar with in vestibular migraine. Then, of course, if you are ill, in the meantime, right? If you have the genetic predisposition, go through life without any problems, some illness, COVID, good example, could trigger the onset of, migraine type of symptoms, or, some really, crazy form of stress also could bring on migraine symptoms in some of our patients too.
I was going to comment, I'm sorry, Abby. I just want to comment really quick on COVID because I wanted to bring that up. This is actually something that I am beginning to ask my patients. When was your most recent episode of COVID? Have you had COVID? Because a lot of times I'm finding that some of their symptoms that they've never had their entire lives are suddenly coming on following an episode of COVID. And then these patients also typically tended to have dizziness during their COVID episode. So there seems clinically, clearly I'm not a researcher. I can't back this up with evidence-based research, but clinically, I'm seeing there's a very big link between COVID episodes and migraine. So are you seeing the same thing?
Yes, so there is definitely a link there. A lot of patients, there are two groups that I generally started to see during COVID. One are patients who had migraine, and then once they got COVID, kind of changed, right? They began to develop vestibular symptoms, and another group is quite well before, a little bit, motion sickness, perhaps early in life, some early indicators that, they had that predisposition to migraine. And then once after they get COVID, then, they develop, migraine symptoms. Yeah.
So what we just discovered is that you can have migraine from childhood, but it can change over time and how it presents in your life. Does the treatment approach then also change? Talk to us about that.
Not greatly. Honestly, I think, all migraine treatments can potentially work, regardless of which stage you're at. A lot of the treatments that we use for vestibular migraine were actually, or are actually, rather, used for people who have, the more classic migraine symptoms, right? The headache type of symptoms, including, for example, the triptans, right? Who would have imagined the triptans, would work for vestibular symptoms, but they do. So the treatments are the same. Even the supplements that we use, like vitamin B2, magnesium, vitamin D, CoQ10, those can work for people, across their life. So, from childhood, even up to adults. I think where there can be some variability, of course, would be the hormonal type of migraine, right? So, in women who experience an increase in migraine attacks during their period, and if they're not planning to get pregnant, then, getting on some form of birth control or hormonal treatment that could, control the fluctuations during their cycle could potentially be helpful. And then, of course, in some women who are in menopause or getting to the perimenopausal period, sometimes getting on, hormonal treatment at that time could be useful as well. So I think that's, where the difference could be. But otherwise, medication-wise, lifestyle-wise, for example, I forgot to mention, getting, sleep, regular sleep, eating regularly, eating healthy, regular exercise, stress management, all those good things important throughout life.
Hey guys, it's Abby here. Unclench your jaw, relax your shoulders, take a nice deep breath. Doesn't that feel better? Thank you so much for listening to Talk Dizzy to Me. One of our missions here at Balancing Act Rehab is to spread awareness about vestibular dysfunction, and the best way to do that is with your help. We'd be so grateful if you took a moment to subscribe, review, and share our show with someone you think would benefit from hearing our conversations. Let's get back to it.
Now, what about for patients who have been on medication? It's been successful for them, but they notice that maybe their symptoms are changing, or maybe it's, they're having some other issues along the way. Is it possible for patients to become used to their medication or have breakthrough symptoms, or do they need a change in medication? What does that look like through a lifespan of a migraine patient?
Got it. Most of the time, if from personal experience, my patients, most of the time, if medication has helped and they've been stable for months, quite unlikely for things to change too much medication-wise for you to develop tolerance. Usually if something were to happen, if it could be like an illness like COVID, for example, or some stress that comes along, usually that can throw things into chaos, and then that's when we have to make medication adjustments, either up the dosage of the current medication or add something else on board, depending where they're at. Tolerance, again, this personal experience, usually develops fairly early on. It's a typical pattern that I see is a patient who starts medication X, right? And then they say that, within a few weeks to a month, everything gets better, but then it just stops and everything goes back to where it was. And then you increase the dosage, and similarly, you find that there is a very brief period where, things get better and then goes backwards again. And that's usually the pattern that I see in tolerance. Now, of course, we have the change in symptoms of migraine. So if a patient has, the headache type of migraines, for example, and they were, very well controlled before, and then develop vestibular symptoms with their migraine later on, then yes, then we have. That's when I will start them on medications for the vestibular symptoms to try and control those as well.
Now, this patient population in particular can be pretty sensitive to meds. How long do you recommend a patient trial a medication, or at what point do you recommend they say, hey, Dr. Bay, by the way, this is not working for me?
Got it. So generally 2 to 3 months for all preventive medications. That's my advice to most patients. And, of course, being sensitive to meds, most of our patients are. I always start off at the lowest possible dose, right? Those medications that can be titrated, I'll start off at the lowest possible dose. And so, of course, that also takes a little bit of time to build up the dosage of the medication too. So got to be a little patient in the beginning. Now, with the CGRP, medications, the injections, that takes even longer. Some people take 6 months up to a year to respond. So again, you gotta be patient with those things.
I was going to ask about recent changes in medical approaches or medication approaches. It's been 3 years since we talked. In that time, have you changed at all your approach to medications or medication protocols with patients?
Got it. Fairly similar still, in terms of different medications. Of course, there's more evidence that the CGRP antagonists can potentially be very useful in patients with vestibular migraine. There's a little bit more data coming out that, supports the benefits in patients with vestibular migraine. Now, are they, this miraculous thing? Do they, work in every single patient? The answer is no, right? If we lump everyone together, as a group, efficacy-wise, fairly similar across the board, compared with the older generic medications. So advice to our patients is always, it's not better. Medications are not iPhones, unfortunately. And so, sometimes, a lot of times, in fact, the older medications still have a role to play. They still do work. So, we have to tailor depending on, our patients' preferences, their medical history, and potential side effects, and of course, desire for pregnancy.
And along those lines, there are other devices like neuromodulation devices that we recommend to patients or patients in this type of diagnoses. Can you talk to us a little bit about those? What do you recommend, and has your recommendation changed based on anecdotal experience with patients or research?
Got it. So the cephally device, of course, would be, the trigeminal nerve stimulator. It goes on the forehead. Can be potentially quite useful in our patients. The good thing about it, of course, is, the headache part of things. There are a lot of patients who have issues with headaches. It can be quite useful. It is a little uncomfortable for some patients. The tingling sensation can be a little bit too much for some patients. But generally, it's a very safe device to use. I've not really seen, major problems aside from, some discomfort. Some patients don't like it feels like painful to them, the ones who have more sensitive scalps. Of course, the vagus nerve stimulators, we have the gamma core device, that's FDA approved for migraine and cluster headache. That also is showing to be quite useful in our patients. A good thing about that one is the treatments are pretty short. It's a 2-minute stimulation, a little break, and then another 2-minute stimulation, so it's pretty quick. I think the latest recommendation for that is 2 times a day. But in the original studies and personal experience, I see 3 times a day actually would be a little more effective. Of course, a little more, that's no problem with that. Those also, I forgot to mention, with the cephally as well and the gamma core, you can use them for rescue too. So, you have this dual function. You can use it for prevention, and then you can use it for rescue. The gamma core device also is really safe to use. One study showed that it did help in patients with triple PD. So, not patients with vestibular migraine and triple PD. That could be a useful one if they prefer not to go on the medication route. There's other evidence in the gamma core side of things that shows that, mood disorders like, anxiety, PTSD, or even some, GI issues, potentially also could be helped by vagus nerve stimulation. Again, no surprise. Vagus nerve is a huge one. It goes to, multiple organs in the body, right? And the parasympathetic nervous system. There is, of course, I'm sure everyone, a few patients have heard about the Truvaga device. So the same manufacturer for gamma core also manufactures the Truvaga devices. The treatments are fairly similar. Now, I've zapped myself with both of them before, just to test them out, right? The main difference I find, right, is that the Truvaga device may be a little bit slightly more challenging to use because you have to, I think, pair it with your phone, right, and then use your phone to, adjust it. The gamma core, it's on its own. You don't need, to attach it to your phone. Truvaga, you can get to about, now this is just my personal estimation, right, based on, how I turn both up to the maximum to see how it feels. With the Truvaga device, I think it gets to about, 50% approximately of the intensity of the gamma core device. Yep. I don't know if they feel fairly similar to me. The Truvaga, of course, it's a wellness device, so it's over the counter. You don't need a prescription for that, whereas the gamma core device, you do need a prescription for it. But I think if you want to, start off with something, right? I'm with the vagus nerve stimulation. I'm not opposed to trying the Truvaga device. I think it'll be a good way to, test it out, see how you feel with it, and of course, if you see maybe some benefit, but not a lot, if you want to go to the gamma core device later on, you could. I don't have much experience with the Neuro-Visual device. That's the one that goes on the arm, little armband that stimulates, and then the idea behind that is, it kind of distracts the brain from the pain of the headache by inflicting some pain on the arm. Don't have much experience using that in patients with vestibular migraine. The other device is, I believe, the Relivion one, which trigeminal stimulation, occipital stimulation. In theory, it could potentially work. We do see that the Cephaly works. I mean, I would imagine that the Relivion also could potentially be helpful. With that one, it's a little bit of a challenging device to use. Last I checked, the contact for the electrodes, you have to really wet the electrode, so it can be a little bit of a challenge to use. So I don't have much experience with that one either.
I was going to ask because, being on social media and with our algorithms being all vestibular and migraine and everything, a lot of stuff gets pushed our way in terms of sponsored ads. And I do worry about this patient population being fed snake oil and kind of preyed upon, just wanting to feel better. So I'm actually really glad you hit on Truvaga, because that was something that was popping in the back of my mind of saying, does this actually work? Is this a thing? I'm glad to hear it's actually kind of partnered with Gamma Core. It's the same company, which is
same company.
Makes me feel a heck of a lot better. Which is, really good to hear. So thank you for being so extensive on all of that. Now,
pleasure.
One more question about the neuromodulation devices. They are stimulating different nerves. So are there different types of presentations that might make you lean towards recommending a Cephaly versus a gamma core on patients? Does it depend on symptoms or how they're presenting?
So most honest answer, there's no evidence to clearly indicate, which direction to go, right? Both of them can potentially be very helpful. Just as, a rough guide. If somebody has, a lot of headache type of symptoms, discomfort, sensory type of symptom, more the trigeminal system, I lean perhaps a little more towards the, Cephaly. Perhaps that could also help those additional symptoms. If somebody has a lot of, maybe GI type of issues, more sensitive scalps, if they prefer, or if they have a lot of, anxiety type of symptoms, then there is some evidence perhaps that vagus nerve stimulation may work better. Again, this is, very general rule. How I personally, decide which direction to go in a patient who's never tried any devices before. It doesn't mean that, this has to be used this way and this has to be used this way. Not at all. It can be used in every single person, I imagine.
I love that you tried them yourself first before you recommended to patients. That's awesome. Now, you mentioned you're doing telehealth. We also do telehealth. And I would say probably, I don't know, Danny, maybe 70% or so of our clientele are this type of patient population with vestibular migraine. I find telehealth works excellent with this patient population because of all the education and conversation that we have in guiding people to empowering themselves to feel better. Talk to us about what that looks like for you, a telehealth appointment versus an in-office.
Got it. I agree. I think when it comes to, vestibular migraine, triple PD, and BDS, a lot of the vestibular disorders that I deal with, telehealth works really, really well. So number one, patients don't have to travel. Traveling, motion sickness, all that stuff is, not good for our patients. The stress of traveling too, also not too pleasant. So that's one thing. The other thing is, by the time, again, most people end up seeing me, they've had multiple tests done already, like MRIs, they've had their VNGs done, audiograms and all that. And so, if I review the data beforehand, there's really not much else that an in-person visit would add. In person, I do like a VNG, V-hit for our patients, and then examine them in person. Sometimes an in-person visit could be useful if I suspect that there can be other problems. For example, if I suspect there's a cerebral ataxia going on or a different problem that may be occurring, then that can be perhaps helpful there. But in patients who've seen, for me, right, patients who've seen other neurologists, and a lot of other disorders have been excluded already. They've undergone extensive testing. Virtual appointment is good. It's convenient for our patients. It's in the comfort of their home, and we accomplish the same thing. Because I think like for you all as well, it's a lot of explanation, counseling, talking with patients, and explaining things.
Now, in terms of preparing for a visit, whether it's a patient's very first visit into their neurologist because they're experiencing symptoms, or it's their 10th visit with somebody or a different clinician or physician, what advice can you offer patients to better or best prepare for these appointments, to get the most out of it, to clearly convey what's going on, and to get the help they need a little bit quicker?
So I think understanding these are subjective symptoms, right? And these are clinical diagnoses. So how we make the diagnosis would depend on, how you describe your symptoms to us, And so as accurate of a description as possible would be very helpful. Terms like, just vertigo, dizziness, those are not that helpful to me. Tell me what you feel. Tell me if you feel a spinning sensation, tell me the spinning sensation. If it's you feel as if you are being rocked around, tell me that. Or if you feel as if the ground is shaking under you, for example, tell that to me. I think that can be helpful, very, very helpful. I think the trouble also is, of course, if patients have seen multiple people before and who are not so familiar with vestibular disorders, then terms like vertigo, dizziness often can be misused, and then when they convey that to us, then we may get the wrong idea. So accurately describing the symptoms can be very helpful to us, like how it feels actually, rather than using the jargon. And another thing that can be very helpful, of course, is the evolution of symptoms, right? If you have symptoms every day, if you have symptoms that come once in a while, if you have symptoms every day that flare up at certain times, understanding those patterns will be very useful. And if they flare up, how long they flare up for? Is it a few minutes, few hours, few days? Is it caused by certain things? If you find that perhaps right now the weather is changing, right? And then your symptoms flare up with the weather, or during ovulation, your menstrual cycle, if you don't sleep well the night before, with stress, with being in a car. All these things I think can be very helpful to us.
I love that you mentioned describing the word versus just giving the word vertigo, because it does make such a difference. And some people, I think, are a little afraid because they think they might sound a little weird or abnormal, but I'm always like, just give it to me. Whatever it is, tell me. I've probably heard it a million times before at this point.
Exactly.
When patients ask you, most patients ask me this before the end of the first evaluation. They say, how long do you think until I'll feel better? Do you think I'll feel better? And how long will it take? What are you telling them?
So I think that most will get better, right? I tell everyone, the likelihood of improvement or symptom remission is very, very good. So most people do get better. Now, the tricky question is, how long it will take, right? Because everyone is different. That's the thing. Biology is a messy thing. Physics, at least, the rules are more predictable. Mathematics, you have predictable rules. But biology is a messy thing. So, that is the part that is very difficult to predict. What treatment would be, the best for you? What treatment would not cause side effects? It's incredibly hard to say. right? I cannot predict side effects. Unfortunately, I wish I could, but I cannot predict side effects. I can tell you what you could expect, but I cannot tell you, exactly what you may experience. I wish I could, but this is the state of medicine we're at, right? And so that has to also play a role in it. If you start a treatment, if you experience, unexpected or untoward side effects, we have to stop, right? Stop, go to something else. And of course, that may add to the time that it takes to get better. Sometimes we have to use several different medications, unfortunately, right, to get better. And, I think for you all also, you may find that certain exercises, that you typically would use may not be so well tolerated. Then you have to switch around. And so that's the tricky part when it comes to biology. The likelihood of improvement is really good. The likelihood of remission is really good. It's just that how long it takes can be very difficult to say.
Do you give any advice to your patients in terms of encouraging them to be consistent with their lifestyle modifications too? Because, the medications and everything can be extremely helpful. But if a patient's also not being compliant or consistent with some of the other aspects, that could really hinder their progression through their journey as well.
No, absolutely, absolutely. So everything, including lifestyle changes, dietary changes, all even vitamins, right? They take time to work. Again, about the 2 to 3 month, mark. Lifestyle changes, I would say, would be, the most important. Make sure you get, enough sleep. Make sure, you sleep at regular hours. Make sure that, you eat at regular times. Don't eat too much of a certain thing. Don't skip meals, for example. Trying to manage stress also very important. But the most important, of course, would be, exercise. So regular exercise is really important. You've got to start somewhere. If you're super dizzy and, cannot tolerate even simple ones, then try, right? Chair yoga. I tell a lot of my patients who, have trouble tolerating exercise, to start at least with the simplest chair yoga classes. See, and then how you, depending on how you feel, you can challenge yourself and move a little further from there. But those things are really important. You have to stick with that. Now, when it comes to the diet, I tell our patients, you don't have to be as strict as that. You see the migraine diet, avoid a lot of things. Can be a little bit daunting, right? So if you right off the bat, if you'd rather not do that, there's no problem. Just make sure, fresh food, keep processed foods to a minimum, caffeine intake, cut it down, no more than the equivalent of 1 cup of coffee per day, no alcohol, salt intake, keep it, low. You don't have to eliminate salt completely or go on as strict as a Meniere's disease type of diet, but don't add too much salt to your diet. Keep sugar also to a minimum. And generally, as long as you follow those rules, most people are okay when it comes to the diet. Now, of course, if you want to implement the strict migraine diet where you avoid all the potential triggers, you can do it too. But you have to be consistent. It takes time, 2 to 3 months, for you to really see its benefit.
What I love about treating this patient population is once you educate, they're really so empowered because there are so many things actually within their control. Now, there are things outside of their control, like weather changes.
Correct.
But there are so many things within a patient's control to take back their lives. We as physical therapists cannot prescribe medication. So I did want to note in this episode that the multidisciplinary approach for this patient population is key as well. For example, a physical therapist like us might work with a neurologist like Dr. Bay, and we also might recommend a psychotherapist to address some of the psychological impacts that a diagnosis like this can have on people. I love that response. And just giving people the hope that they will get better, because so many people have experienced symptoms for so long and have not seen necessarily the right providers to give them that hope. I think it's great that people like you exist.
Thank you. It's a very treatable condition. A lot of people do get better. So, it takes a little time, but, people do get better.
Yes. Well, audience, thank you so much for joining us today. Dr. Bay, you are the best. Can you tell us what states you're licensed in?
Lord have mercy. Texas for sure. Currently, Arizona, Alabama, Oklahoma, Colorado, New Jersey, Washington State. I may have missed something there. Georgia, email us, let us know if you need to, if you're not sure, if I'm not sure. Or you can check out my clinic website. I have the full list there. I can't keep track of these things.
I'm going to need you to add New York. I need you to add New York. Florida would be great. If
Oh,
that's
it's Florida. I do see a license for telemedicine in Florida. New York, unfortunately, not yet. California, not yet. And a few other states, not.
We'll be sure to put all of that information in the show notes too, because I have a feeling that like your first episode that is very, very popular, this one will be too. And we're so grateful for your time and all of these updates. This was a wonderful episode. Thank you so much.
Thank you. Thank you for having me.
This podcast is provided for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition.
The content of this podcast is based on general knowledge and information available up until the recording of this specific episode. Medical knowledge and practices may evolve over time, and new information may emerge that could change the understanding or treatment of vestibular dysfunction. It is important to consult a qualified healthcare professional for the most up-to-date and personalized advice.
The information provided in this podcast is meant to complement, not replace, the relationship that exists between a patient and their healthcare provider. It is intended to empower patients with knowledge about vestibular dysfunction and its management, but individual cases may vary, and treatment approaches should be tailored to each patient's unique circumstances.
By listening to this podcast, you acknowledge and agree to the terms of this medical disclaimer. The organizers, presenters, and creators of this podcast are not liable for any actions or decisions taken by individuals based on the information presented herein. Always consult with a qualified healthcare provider for medical advice and treatment.